very much, first of all, Dave and the other organizers for inviting me. Okay, so the topic, as you see, is like mainly the neuromodulation and what's palliative in pediatric epilepsy. Okay, so I have no disclosures. So the objective would be like review the indications, like what can be the clinical and technical aspects, and some palliative techniques. Okay, so the history of neuromodulation is not new. In 1580, Scribonius recommended torpedo fish for shock for the pain. And I think it's a very interesting story when I figured it out that somebody with gout had the shock with this torpedo fish and the pain was gone, and they realized and they started using it for the pain management. So that is the history. And then in the late 19th century, Horsley stimulated the cortex in an epilepsy patients. And then we know early, like 20th century, then Bailey and Bremer showed EEG changes on stimulating the vagus nerve. And then in the mid 20th century, we figured it out in humans that stimulating the VNS or with the vagus nerve can produce the synchronization or the desynchronization of the cortical activity. And then in the animal model, it was seen that in the late 20th century, that if we stimulate the vagus nerve and these stimulations can desynchronize the cortical activity and hence can help with the seizure control. So when to consider the neurostimulation? We all know, like traditionally, we all like to comment on the drug-resistant epilepsy, but I think there is a talks and like everybody's thinking more on like, do you really need to use the two medications failure, particularly if they have a lesion? Anyways, like the drug-resistant epilepsy, particularly in those who have the eloquent cortex involvement, there is no need to wait, and I think this can be started early on, though we don't usually, but I think it should be considered early on. Or if it is multifocal or regional epilepsy, normally in patients who have failed previous surgeries or who are not the surgical candidates, one due to eloquent cortex or other reasons, those who cannot try the ketogenic diet, those who have like the family doesn't wishes or the patient doesn't wishes, then this can be another like armamentarium to explore. So how it works, basically we deliver a electrical stimulation to the specific neurological site, and that alters the neuronal activity. So just disrupting the normal or typical behavior, it can provide the modification in the epileptic network. And with the long-term changes, I think there are anatomic changes that happens that permanently then changes the behavior, the underlying behavior of the neurons, and hence help us in the long-term seizure control. From the previous studies, particularly like I think the hallmark for the epilepsy world is still the vagus nerve stimulator, because most of the studies are over there. And we have seen that these can increase or decrease the neurotransmitters in the brain that have been measured in the CSF of the patients, like with the chronic stimulation with the VNS. There may be the areas with the cerebral blood flow decreased or decreased blood flow to the thalamus that helps desynchronize the neuronal activity. And I think also there is like a direct, the RNS provides us, like we can see that there is a direct ictal disruption with the high frequency stimulation. Okay, so neuromodulation options, if you think like there are many, and I think like some of the abbreviations were like you want to see like, okay, you memorize them so that you don't lose them. But I think the three main are the DBS, RNS, and the VNS, which are the FDA approved at this point. So the neurostimulation, when it is being delivered to an incipient seizure, it is the closed loop. And I think that the RNS and the new version of the VNS, it provides as it stimulates in response to tachycardia detection. And then the open loop when you have a timed stimulation. And some of the techniques I mentioned, if they get approved through, so here I want to see like the chronic, next to the DBS, the chronic subthreshold cortical stimulation. It is also a form of the closed loop, and I think it has a very promising results. Like the Mayo Clinic published it. It's 32 patients over a period of 4 years, and I will go over, like I will mention it, but I wanted like, okay, just to pick up like another abbreviation from here would be this one. Okay, so we know like the cortex have heavily to and fro connections with the thalamus, and I think that was the basis of the exploration into that avenue, that we use these connections to modify the epileptic networks. And traditionally we know like more heavily connections of the interior nucleus of the thalamus is with the limbic system or the papias circuitry, and the centromedian is more with the frontal parietal connections, and the pulvinar with the occipital, or more with the posterior quadrant connections. So deep brain stimulation, it's an open loop. The initial work with the Panfield and Jesper, and later the Fisher and Velasco work helped they develop this technique. Like, okay, why don't we stimulate the interior nucleus of the thalamus, or the deeper the thalamic nuclei, to see their role in epilepsy control? And it was approved in U.S. in 2018. And these are the controlled studies that led to that. The initial studies, if we see by the Von Braun and Wright and Velasco, showed the cerebellum improvement. And now there is a small typo error. I apologize for that, but the centromedian studies by Velasco and the Fisher. So the Velasco showed 50% reduction in 80% of the patients. Fisher's study, that was a double-blinded crossover study, showed about 50% reduction in half of the patients, 3 of the 6 patients. It has total of 7, but 1 dropped out. So 3 of the 6 patients, they showed more than 50% reduction. And similarly, the Velasco in 2010 showed about 50% seizure reduction in 90% of the patient. And then the famous trial that was the Fisher that did it in 2010 with 110 patients, the Sante trial. So that was a double-blinded randomized controlled trial, multi-center, and they saw the blinded phase. There was like a 40% seizure reduction in the stimulation group as compared to the control group that only had a 15%. And at the end of their study, it was like more than 54% were responders with a mean seizure reduction of 56%. Plus 14 like seizure-free for more than 6 months. I think that was the benchmark that was used, that was more common. Now, a follow-up of this study, 10-year study by Salanova, showed that the median seizure reduction in seizure frequency reduction was 75% at 7 years. In this study, they also showed the 5-year follow-up showed like there was clear quality of life improvement. They didn't comment on their study, but they did say like the risk of SUDEP decreased in this cohort of the patient. And then this is like a nice systematic review, including 21 studies. They found 40 patients, pediatric patients, in which the thalamic stimulation was done. And 24 of them was the anterior nucleus plus centromedian, unilateral or bilateral. The rest was subthalamic and other avenues explored. And they found that the meaningful contribution was by the stimulation of the bilateral anterior nucleus or the centromedian nucleus. So responsive neurostimulation. So after the thalamic stimulation has been there like way before. Then like we decided to approach directly on the cortical stimulation. So targeting directly the ictal epileptogenic zone in the cortex was done with the neurostimulation, and we know like during our ECOG recordings that you can give a brief the train of the stimulation, and you can disrupt the after discharges, and it was approved in 2013 in patients who are more than 18 years of age with less than 2 foci. This is just like the CT scan of a person who has the device. The device controls 12 minutes of ECOG data at any given point. So we as an epileptologist divide the epochs, like usually it is the 90 seconds, but depending on the seizure duration or where you want to capture the onset, they can be changed up to 3 minutes of an ECOG length. But until you download that, the device can only hold the 12 minutes data. So either the patient downloads it repeatedly, or they can use the magnet to mark and keep it until they are able to download it. And there is the below is the real time, like the ECOG from the RNS, and you can see the onset detected by the device, treatment delivered, and the seizure aborted. So this was the original pivotal trial by Martha Morell they had 191 individuals with drug-resistant epilepsy who had more than 3 focal seizures per month. And after the 12 months baseline period, the device was implanted. After a month, the stimulation was initiated, and then they evaluated them at the end of the 3 months period, a blinded period, and after the blinded period, everybody got the stimulation. So if you look at that, I think this is which is the pointer. Okay, so I mean, like if you look at that, like after the implantation during the first month, everybody got the improvement. Both the sham group and the stimulation group, they had the improvement, and then the seizures reoccurred. But the stimulation group stayed with the less seizure burden than with the sham group. That during the blinded period, the seizures again increased, and when the stimulations turned on, then they started responding. But you can say the delay in response. So it also shows the longer you stay on the stimulation, your results are better, which I'm going to show next. And this is a 9-year follow-up by Nair et al. That showed like at 9 years, their median seizure reduction was 75%. And there was 73% responder during the study. 35% was like super responders who had more than 90% seizure freedom. The RNS, we can use it as like a chronic ECOG in the real world. Patient can have it, can go home, and we can manage it. I think the initial study in the Rush University, they did it like, and they proved like 20% of their presumed laterality to the temporal lobe onset changed after the chronic stimulation with the RNS. And these results were reproduced by Larry Hirsch in a larger cohort of 157 patients, in which he showed like 16% of the patients with presumed bilateral temporal lobe onset seizures actually like about 6% of them were having the unilateral onset, but they were presumed like bilateral. And the 10% of them was bilateral, but more than 90% burden was on one side. So ultimately getting the resection, and they change it from the drug resistant to drug responsive, the epilepsy. What are the neuropsychological benefits? The initial pivotal trial, they did the neuropsychological evaluation at 1 and 2 years post-implant, and they didn't find any cognitive decline. Rather, they reported that there was improvement in naming and verbal memory and visual tasks. There is like a recent study by Taggart et al. With the 50 patients, though the follow-up duration is only 6 months, but they didn't report any neurocognitive decline. There is a good like a systematic review by Lamb in which like they have 29 studies showing about 770 patients with no neurocognitive decline, and this also includes the first 175 patients for the RNS trial in this 770 cohort. And then at our center, we did this, the list learning task, and during that we stimulated. So we had our RNS implanted patients. We gave them a list learning task, and during that we stimulated them on every third word, and they were blind. For the first session, the neuropsychologist was blinded, and then we repeated like recall them at 20 minutes, and then we crossed over the same cohort, and we found like there was a verbal memory improvement. And we are doing a more refined version, and we will see like, okay, we are seeing good results with them. Okay, so this is the now coming to the real world data out of the pivotal study leading to the improvement. There are many studies now open, like centers are expressing their experience with the RNS, and this one by Razavi showed like the seizure freedom with the long-term treatment. The seizure freedom periods can be extended, and they showed like about like 20% of their patients were like having more than 1 year of seizure freedom. Many other avenues like the RNS was being, so after the cortical stimulation, there was like, okay, if it is working, let's explore to the other avenues. So there was the patients with the LGS in which like the thalamic implants were done, patients with the absence and the generalized tonic-clonic epilepsy seizures in which like Dr. Richardson group in the Pittsburgh, where Dr. Jorge is now, they published in the generalized epilepsy improvement with the bilateral center median implants. And then our center, we implanted about 7 patients with the TSC, and we had 86% median seizure reduction at a minimum of 17 months of follow-up. And then our overall experience with the thalamic electrode, like these are the thalamic implants that have more than 1 year of follow-up, and we had 11 of them with the centromedian, 2 the anterior nucleus, and 2 are bilateral CM with the 9 unilateral, 8 of them are bilateral. And why I said it's important, like if they are multifocal and they are having the seizure foci in the both hemispheres, we use direct stimulation in one hemisphere, and we target the CM on the other side. So that's the contralateral one. But we found 46% were responders. And I put the etiologies over there because there were less numbers, so I thought like you should know. So focal cortical dysplasia, TSC, and unknown epilepsy, we had a good response, like more than 50%. And actually it is 60 to 80% seizure reduction. Yeah, but we use the parameters as responders versus non-responders. The rest are non-responders. Yeah, but I show you like with the time, like how it changes. So this is our overall experience. We crossed 90 now numbers at our center, and this is the first 66. We divided them in 3 groups, age range 3 to 11, 12 to 17, and 18 to 21. And you can see the younger the group, the greater is the response. Even the responders are 69% if they are younger than the 12 years of age, while the 12 to 17 is 60%. And the 18 plus are like about 50%. Similarly, the seizure freedom and the super responder group is the same, the younger group. And I think that goes, we all know this notion, earlier to treat or lesser the duration of epilepsy, you get the better the results if the treatment or intervention is being applied. This is our overall, all the data, all the patients. I want you to follow here just the shades of the green. So the solid color is like seizure freedom, and the lesser and lesser colors are basically with the less freedom. The most important point is like we found that after 3 years of stimulation or 3.5 years, everybody was responding. Everybody was responding. No was worse, or like they had some response. So it's the time. My first patient became seizure-free at about like closer to 3 years after implantation. Till to date is being seizure-free for almost 4 years. However, the other interesting phenomena, and I heard like other centers are also seeing, is after seizure freedom of 2 years, no seizure at all on the ECOG, started having electrographic seizures, no clinical seizures. Talking with the family or in the school or in the class where they know like he was in his normal and there was no question about the seizure. So we see them. And then that's why you see like at 72 marks, there is some red line. So they have some seizures. I think important to note is like, okay, how many of these are completely seizure free? Okay, so the palliative approach to the patient. So I think when I saw this, I was like, okay, everybody's talking that, and that should be a separate talk. But I think overall, then if you look at the essence, I think anything that doesn't cure you is palliative. So basically, whatever we do, that the attempt is we want to control the seizure, make the person seizure freedom. That is the goal. But in the real world, how many times we do achieve that? Okay. So I think the palliative technique focuses on you increase the quality of life, you decrease the seizure burden or the severity of their seizures. So traditionally used like the genetic epilepsies or multifocal epilepsies, we were like, okay, they are not the resective or surgical candidates. But yes, laser ablation has changed that notion. You can go and you can pinpoint, like with minimal morbidity, you can go and treat or focus most debilitating seizures. And I think to me, all these techniques are palliatives. The neuromodulation, it doesn't cure you, though it can be the notion it cures you. It only cures a very few patients. My seizure freedom, we have like about 6 or 7 patients who are seizure free out of the 90 patients that I had. So it is not a cure. It is still a palliative technique. Yes, they respond, they are good. And in the long term, if you see like they are the palliative, whether it's the VNS, whether it is the RNS, DBS, or the NEWS, I think they are exploring more avenue with this neurostimulations. One interesting point, although I'm not presenting that, but I wanted to tell you, like my personal, as I'm learning, I'm young, like in the field, but if you look at the VNS Elliott study by the NYU group, at 10 years, their mean seizure reduction is 75%. You look at the DBS study by Selenova, 10 years, 75% median seizure reduction at 7 years. You look at the Nair et al., 9 years, 75% median seizure reduction. The numbers are exactly almost the same. all techniques work. I think it is just like these are relatively new techniques or less number of patients, they look more appealing. But honestly, they all are doing it. And another interesting thing is we have also found like patients who have VNS, right? We are exploring it. I have like 4 patients, 2 of them responded. We added them on VNS to RNS. And they responded. So I don't know what is the synergistic effect to those. And the others ones, as we mentioned, yes, the corpus callosotomy, these all techniques in a given patient can be curative, and in the other patients can be palliative. So I will finish my talk with saying all the surgical techniques or all the treatment modalities that doesn't provide the cure to a patient are palliative, and we should not hold any of them from a patient because it cannot cure the patient. Thank you.